To say, oh, there are 2 or 3 or 5 or 9 people interested in one thing. So you guys, you're the generation where I didn't say invent attention switching, but you've lived with attention switching from, probably even before you appeared on Earth. So you folks are pretty good on that. And if it's just for something and you have a kind of question where it just doesn't fit by pecking a few letters on a keyboard and you just have to ask it, it's okay. Raise your hand. I'll call on you. Maybe I'll call on you. All right. But the point is we want to have multi-modes of people want to get stuff across. All right. Jason, thank you. That was sort of a great introduction. It really was very helpful. So thank you for that sort of kind of framing. Yoksin, why don't we give you the mic for here, and don't attempt to comment on Jason's thing. Just paint sort of a verbal picture of what you do, of what sort of is the mission of your organization. It's sort of so large and so multifaceted, you sort of have to figure out how to aggregate the detail. But help people understand a little bit about your everyday life and reality and what you're doing with your organization.
Well, thanks, Steve. And also would like to thank Jason because he gave a very good overview. And I'm sure you remember his last comments, right, that it is very difficult to deal with doctors. So I have to deal with the whole spectrum of doctors across public health care, right, which comprises of actually 6 regional health systems and 1 AIC. Altogether, we're dealing with 40,000 healthcare users, right, of the system. So what I do is, I actually design, architect, and implement solutions, right? Many of these solutions are also outsourced to our partners, right? For example, our billing systems, the SAP systems, for example. Okay, some of the lab systems, radiology, and so on. So we actually provide for the entire clinical and business systems, as well as operate healthcare cloud, right? Upon which all these systems are actually kept and they are provisioned. So my goal is to avoid proliferation of systems. And why do I say that? Because IHIS was formed out of the merging of the 2 IT departments in 2008. At that time, we had two regional health systems. One was called the Singapore Health Services. The other was the National Health Group. Right? So one is national, one is Singapore. Actually, it's the same, but it's just 2 groups, right? And since then, we have evolved to actually 6 RHSs. So, when any of these RHS evolves, right, I think the tendency would always be to have your own, to craft, your own path ahead and to have your own systems and so on, right? So the goal for IT is to ensure that we do have patient-centric systems. And what it means is that the systems must follow the patient, right? And wherever the patient goes to. So despite the varied RHSs that we have, right, the goal of IHIS is to integrate all of them. First by avoiding proliferation. Second, if they do proliferate, then we have to, at best, harmonize them so that they actually have the same standards. All right. And thirdly, is to consolidate them after they have, been around, and that's what we've been doing. Because even in 2008, right, there were many different systems, even with 2 clusters, because every department had their own, right. And even in a department, you could have multiple systems. So our goal is to actually consolidate these systems, and we have actually achieved quite a bit now with the National EHR, which is the glue that is that nationally binds all the electronic medical records together on the ground. So on the ground, we actually have 3 types of electronic medical records, right, among our 6 clusters, right, and they actually provide the daily transactional systems that facilitate the medical orders, right, by the doctors, as well as treatments and the follow-on actions by nurses, pharmacists, and so on, right, in the provision of care, right, in whatever setting the patient is, that means whether it is in the outpatient setting, inpatient setting, and so on. So they use very much integrated systems. That's why our name is Integrated Health. right? And we hope to be integrated health more than integrated health care, right? So that actually speaks to where health is going to. So health should actually be continuously provided, right, at the home, right, in whatever setting the patient is, right, and beyond, the inpatient and outpatient settings, which are actually traditionally thought of as where the patient is usually encountered.
Yuxin, just two quick things before we go over to Bastari. You mentioned electronic medical records, right, or EHR, electronic health records, and it's sort of a buzzword that you don't even need to know anything about it, and you sort of get the idea what it is. But you might explain, is that just within the public sector hospitals? Does that go to your GP? What's sort of the span and scope of that? Not everywhere in the world, but here in Singapore.
All right, I'll talk about the reality first and what it should be. Okay. First, the reality. The public healthcare groups, right, which is all the clusters I spoke about. Every one of these entities is equipped, right, with one of those 3 EMRs, electronic medical records, that's on the ground. Okay, why do I mention 3? Okay, there are 3 instances, right? So a few of them, like for example, the Sing Health Group and the Eastern Health Alliance share an instance of an EMR, right? And what the EMR does is, I told you, right, it does electronic orders, as well as it tracks all the treatments, it tracks all your lab results, all the radiology reports and scans, and everything about the patient, right? Okay, so we have these EMRs, right? So they are very much equipped in public health care. Now, private health care, right, EMRs are not supplied by IHIS, right, as yet. And I meant, when I talk about private health care, I meant groups like the Parkway Group, right? We have the Raffles Medical Group, and then the Farrer Park Group. These are examples of private healthcare groups. Okay, these actually have their own, IT systems or EMR systems that are provisioned by themselves. Okay. Then we have the GPs, right? GP groups are, there are about 2,000 over GPs, right, in Singapore, general practitioners. So these people will be actually equipped with an EMR that's going to come from the Ministry of Health.
But not yet.
Yeah, correct. Not yet.
Right.
Okay. Right, so that's that group. Now, what about the nursing homes, right? And Jason talked about intermediate and long-term care facilities, which are the community hospitals, nursing homes, right? Daycare centers, right? So for the community hospitals, which are actually not run by government, they're usually run by the VWOs, which is voluntary welfare organizations. Could be, the Buddhist groups like Ren Hospital, right? Or it could be Christian, like St. Andrew's Community Hospital, right? So these groups or these community hospitals have been equipped recently by the MOH and by us, IHIS, through IHIS, right? With an EMR, okay, and also with a billing system for claims, right? For them to be able to claim for the patients that they see, right, from the government, right? So the community hospitals have been equipped. What about the nursing homes, right? Now, the nursing homes can ill afford any IT system or IT professionals, right, at that. So they have also been equipped with a free system provided by the Ministry of Health, right? So these fractions are actually provided, and increasingly the GPs will be provided over the next 3 to 5 years, right? Only because I think many of them are quite resistant as well, right? And for the private healthcare groups, right, we're still talking about that, right? But by and large, they already have their own EMR systems. Now, so what's the game plan across the whole country? So the game plan is that the patient goes, right, between public and private healthcare and anywhere else, right? So his record will be seen in the national health record, right, which actually integrates into the various EMRs to present the summary record of the patient in a longitudinal manner, meaning that it has the historical and chronology record of what the patient did at each of the settings. So that is the to be. Okay, that will take another 5 years.
Okay, thank you. Well, Starry, would you like to share, not so much from your past years in banking, but in your more recent years in one of our public clusters and the various things that you do there?
Sure. Well, I've been told that I'm working in the Kutipal Hospital itself. It is up in the north. We are one of the 6 clusters. So maybe just give you a very brief history of what we are actually doing. Right? The hospital only opened in 2010. And what we actually observed was within a short span of, I think, about 7 months, right, the hospital was filled to the brim. All the beds were taken up. So we sort of realized, I think Jason has alluded to the fact that, with the population aging and all that, the silver tsunami is definitely coming. So, it's just not possible for us to continue building hospitals. So we need to take a look as to why the phenomenon itself. And why is that happening? So there was a project group that was formed, and we then started to actually go to the homes and to actually seek what is actually happening. Because we did, prior to that, what we did was we actually did some hotspotting. Right? We went through our database, run through, and then understand, right? And what we discovered was basically that over a 6 months period, there were this group of people who we call frequent flyers. They kept coming back to the hospital. So we then started to go visit the homes to figure out what actually happened. Now, if you remember, I'm not sure if you caught what Jason has spoken about, is when they were in the hospital, they were given the perfect care. Nurses were there to look after them. Medications were taken care of. The diet was taken care of. If you needed to go to the toilet, press the buzzer, nurse will take care of them. No falls, properly nourished, properly medicated. Perfect. What happened when you go home? This is an 85-year-old man. And who's looking after him? His 82-year-old wife, who is just as frail. Right? You look at the homes, what happens? There's no proper bar, support bar for him to hold on to. And what did he use? He just simply hang on a towel rack, a belt, for him to help to get up when he sits from his toilet. Right? And you look at the state of the clutter in the home, is it ideal? Obviously not. So we begin to do this home visit, and then from there then the program then came out to say that how do we then help to prevent the frequent visitors? And that program then evolved into what we call aging in place. Yeah, so that's how it came about. So the aim of the program was, what is it that we needed to do in their homes to make sure that when patients are discharged, they are able to stay at home. Right? So the whole emphasis from the hospital is actually now to consider we have to move beyond the hospital walls. It is not possible for us to just simply stay within the hospital and expect to see improvement. Because otherwise we will be like sitting down, not knowing what will hit us. Okay. So we have the aging in place program, so that's basically saying that once the patient is discharged, what do we do? So we have to identify which were the patients that needed that kind of special care, and we actually have a team that we set up. And we are very clear in the program itself, it is not supposed to be radicalized. Because I think also, I hope you caught what Jason mentioned, that health is not just about medication, treatment. A fair bit of it is also to do with social, family support. So what do we need to do in order to get them to stay home? So that is what OAS program is. And when you start looking again, when you start thinking about it, is in the whole idea of building this community service, we then start thinking, well, does it make sense for us to just simply, so if you're at hospital, the discharge is there. So we start thinking, hold on, yes, we solve this part of the problem, but what about trying to prevent them to come in too early to begin with. That's when the whole idea of nothing to do population health come about.
Well, sorry, so at KTPH, that's our short name for Kutek Quad Hospital, and the larger group they belong to called Alexandria Health. What are some specific, I understand the word population health. There's a population, I need to worry about their health. But what are specific things that people do that a hospital like yours would do? You're in a catchment area of, how many people live in the catchment area of?
About 700,000.
Okay, so that's a pretty healthy sized population. So put in plain English, let me tell you some of the initiatives that we do that's what we refer to in our organization as population health.
Sure. I think when you understand population health, it means it can be as broad, but it can be as narrow. For us, what we currently do is that we're going to do it in stages. So for the moment, what we needed to do and what our overall strategy is, one, as I mentioned, we know we have a catchment area of 700,000. Of that catchment area of 700,000, we know about 500,000 our actual target, because these are Singaporeans and the PRs that we need to serve. But do we know the state of their health? We don't. Right? We know some, but we do not know all. Because what we wanted to do was, if I need to be responsible for this, we need to know what is the state of health. How healthy are they? Just like any other company that you deal with, right? If this is a market, you need to know, get a better idea of exactly what is the market like, who are you serving, what are their needs. So we need to go out and find out. So that's what population health aims to do. So what do? We actually go out and do health screening. We need to segment the market, right? So again, if you remember what Jason said was, who are at risk? We need to focus. So we go after those who are at risk. And nationally, there is already a standard to go and say that anybody who is about 40 years old, they ought to go for screening, health screening, right? The health screening that we talked about is basically the simple health screening, doing the three, I guess we will call the three brothers, right? So when we go after, we want to go in and measure the blood pressure. We want to draw blood, fasting blood. Why do we do that? Because we want to measure the blood sugar and cholesterol. These are all more cardiovascular risk related, because that is actually, if you look at in terms of the top 10 chart in Singapore in terms of the cause of death, it's right out there. Okay. So that's why we go out and do that, right? And we go out and screen. I mean, we aim for 40 years old and we go and screen. Now, sounds easy, but in reality it is not, because if you start thinking that, how do we go about doing that? Right? Think about it. If you are in my shoe, you have, I think roughly about 40 years old, maybe about 200,000. I need to go and find out 200,000. What is the state of health? How would you do it?
Right. You can't just send them an email, because they're either not going to get it or they're going to ignore it. Right. Exactly.
And I need them to come faster for 8 hours for me to draw the blood. Okay, so that's the kind of work that I'm doing. Now, we are also at the same time looking into, in fact, let me introduce a bit about the hospital itself. Since the opening of KTPH, which is an acute hospital, we have since also at the same time built a community hospital. So that is for the step down step. That will be open end of the year. Right? So from acute to step down, that's part and parcel of the overall care continuum. So what we are trying to do is basically, once you are discharged possibly from an acute hospital, then instead of staying in an acute hospital, it's very expensive, you're then pushed on to the community hospital before you then are discharged back to the homes. And I think government has also announced that we are going to build another health campus in Woodlands. Right? They will add another acute hospital, a community hospital again, and a nursing home. Right? So we are going to be a very unique institution in between these two that we're building, we have already in the midst of building two other so-called healthcare facilities. One is the Admiralty Medical Center. That is supposed to handle basically more specialist outpatient care. Basically, it's step-up care, secondary care. That's coming up, I think, by 2017, thereabout. And we are also going to start a new primary care, a new model for primary care. And that's why I'm involved in the project.
Jason, you gave us, sort of the overview of the health system. You said a little bit about the Agency for Integrated Care. Can you just sort of go back and, what was it a few years ago with all the things that we were doing at that time with the hospitals and the Ministry of Health? What was the gap that we needed for AIC? And, what are the handful of things that AIC has done over the few years? And in what way is it similar or different to things going on in different countries?
Okay, AIC started the original element, started in 1992 as Ministry of Health. It was called a care liaison service, because at that time Ministry of Health found that the patients who were coming out of acute hospitals who needed to go to nursing homes couldn't find their way. They were bumping around the system. They would book places in 3 nursing homes, turn them at one, and not tell the other 2 who keep the beds open for unnecessarily, and so on. So this care liaison service was like a clearinghouse for referrals from acute hospitals into nursing homes, and that's how it started. Time passed, and it evolved a little bit, but towards the end of 2008, 2009, basically it was realized that you need to go beyond just facilitating the referrals, that the VWO, the voluntary welfare organizations, needed to be beefed up. They need to increase capacity, increase capabilities, increase quality of care. But who's going to do that? And ministries, mostly what we call policy hacks, who they write papers, but on the ground it's a little bit different, because you have to relate to people, and it's very fragmented. So the idea originally was to create an agency that was I mentioned the catalyst, that allows for that would insulate the on-the-ground operational work from the Ministry of Health and deal with the multiple parties. There are 65 nursing homes in Singapore, 30 over, the numbers are graduating very quickly, 50, 70 day-based, center-based services, and a handful of home-based services, and they're all different sizes, different shapes. So rather than Ministry of Health doing it, basically Ministry of Health created an agency to insulate themselves from the work. So that's how it started. The original mandate was to look after the ILTC sector in terms of capacity and capabilities, to help start off the regional health systems, because we were feeling our way about what on earth is a regional health system at that point in time, and with a little bit of fund holding, fund management. Since then, in 5 years, it went from 30 staff to 500 staff. Along the way, they added in social care services, added in administration of major monies that were given out to the VWO sector, and even to some to the private sector, including in Singapore, our community civil trust fund, the total community healthcare fund. There's a lot of money in the system because people want to put money to this sector. But the thing is that how do you make sure the money is well spent? So all these monies eventually end up somewhere within the Ministry of Health, and they get passed on to AIC to be the administrator. They wanted to also, Ministry of Health wanted to engage the primary care sector, the GPs, and get them to be more involved in the care of chronic disease and so on. Again, how do you, from a Ministry of Health standpoint, how do you get the ground to move? They gave the job to AIC. In 2012 or 13, there was a review of the National Mental Health Plan, and they said, we need to have more impetus on this. We need to form a group of people dedicated to running this thing. But rather than form another agency, they made a division under AIC yet again. So in terms of complexity, AIC is going maybe 10 times. In terms of staffing, it's from 30 to 500. So it's a very complex organization by now. Still trying to find the right adjective for it. It's not pejorative.
Let me respond to something. One of the options that people get to tick on, there's this question is, what is unique about Singapore's healthcare system compared to other OECD countries? All right. OECD are sort of the well-developed countries. I think they're in multiple parts of the world, not just the Western countries, but they're the well-developed countries. Now, to be honest, that's an answerable question. And even though the spirit of that question is good, I'm not sure actually attempting to answer that question is useful to the people sitting in the room. But I'm going to take the spirit of the question. I'm going to take the spirit of the question of one being, help me understand what you do by making a comparison and contrast in a limited way to what you know people do in other countries who have similar functions. So don't worry about all of OECD, and don't worry about all of Singapore's healthcare, because that makes the question unanswerable. But given that, one of two things I know has to be true for all three of you. People from foreign institutions come to visit you, and on occasion you've gone and done your little study trips to sort of counterparts in foreign institutions. So it doesn't have to be systematic, it could just sort of be very targeted and ad hoc. You have a few comparative reference points. That would be true for all three of you? All right, I think so. So just briefly, from what you know about what we do and what some places elsewhere do, how is AIC sort of similar and different in just one or two or three other countries that you're familiar with?
I'll start by saying that Singapore is different from the other countries that within the OECD and elsewhere, because Singapore is, those are countries, Singapore is a city-state. And that's a huge difference. So if you really want to compare Singapore with other countries, you should be comparing with New York State, London. You do not compare Singapore with the whole of the United States and so on, because they are different organisms altogether.
As you helped us to understand, scale is important.
Yeah. Yes. In terms of the work, so if you compare AIC to an enabler agency within any city around the world, where the government farms its work out operationally to a group of people, that would be it. In terms of a counterpart to AIC anywhere else in the world, at a country or at a state or city level, I actually have not come across any such agency that covers the whole width of what's happening. Because AIC actually does, it provides certain limited services directly to patients. It is a sector developer in that it looks at the sector and says what needs to be done for the sector to do better to serve patients. Without actually serving the patients themselves, we look at the sector and say what we should do for it. Sort of like what the tourism board does for tourism in Singapore. They don't see the tourists, but they help the hotels and so on. AIC is also a fund administrator, which is equivalent maybe to the US HECFA and so on, where they look at some streams of money and they administer those streams of money out to people. And I suppose one more would be a general dog story, where the Ministry of Health needs something done. There is no agency that would do it, and AIC gets the job. Sometimes, and they're having programs where there are two parties out there who are both doing similar things and they don't like each other. I mean, the people there are in those two different places because they don't like each other individually anyway. And AIC becomes the intermediary because they don't trust each other, but they would trust AIC in the meantime. So we end up managing the funds for two of them because neither of them wants the other one to manage the fund. In some cases, neither of them wants the other to manage the fund, but they don't want to go through the hassle of managing themselves, so it doesn't get done. So AIC does the grunt work.
Now, Bastari, I'm sure you've had numerous visitors to your organization and occasionally some overseas trips. What's your own sort of mental model of compare and contrast to some interesting other country examples relative to what you're doing?
Okay, I think one of the key contrasts would be the AIP. It's our program, right?
AIP means?
Aging in Place.
Okay,
so that's the one that I mentioned earlier, the one that we sent. So this one actually, in terms of structure itself, we use, and what we are now trying to, what we have in fact created is basically a new career path for the nurses, because now nurses are able to develop themselves as community nurse. And their job is basically to go out into the community, work, and see the patients. And the nurse actually is an all-rounder, not just simply looking after so-called just the common medical needs. Right? So when the nurse actually goes to see a patient's home, she is supposed to solve the patient's problem. And that's not just simply restricted to the medical problem. It could very well be a case where she has to go and make sure that, for example, as I mentioned to you, that there's no grab bar, then we're going to work with the Housing Development Board to go and get that fixed. There are certain funds that's running through. You may have to go and do certain alteration to make the home more safe. And if, let's say, the particular patient needs some home care because they can't look after themselves very well, they're going to work with all the VWOs that is running through. They need help with food, right? Again, you work with the VWO to run through. So the nurse basically saying you go in, you are sort of like a jack of all trades. You are the so-called case manager to run through and see to it what's available, the resources that are available out in the community, work with the VWO, arrange for it, right? So this is, I think it's quite a unique program. We in fact actually submitted it as a submission and we actually won a UN prize for it just last year. Okay. So that's quite unique and different. And I guess the other thing for us is maybe there's a very peculiar to our own hospital itself. Steve, I think you've been to a hospital before, you know what is, we do get a fair bit of visits from other hospitals who want to come in to go and see the actual design of our hospital, where we turn the hospital into some sort of a healing center where we actually develop greeneries. So we want to be sure that the patients actually can, as part and parcel of the healing process and so on, right? And I think the other thing is, I guess, from our perspective is that because we are a public institution, we are not, in a sense, that profit motivated. So we do have, I mean, if you look at a lot of our doctors, I guess coming in from an industry that's literally dealing in dollars and cents, and now coming into healthcare, I look at it from, it's an eye-opener for me personally to see. We have a lot of passionate doctors who truly have the interest and the welfare of the patients in their hearts, and will go out of their way to do things.
This is important. This is a guy who spent a lot of years in banking, so remember that when you make your career choices. Okay.
So that's quite unique, right?
Yoksin, you must have a flood of visitors. Even before you did the EMR project, I'm sure you had, people come and visit and benchmarking and what do we do, how do other places do. And then sort of relative to the EMR space, I'm sure that's like a whole gigantic wave of visitors just for that. But help a little bit with the international compare and contrast, at least ones that are important to you as you sort of understand what you do.
Okay, I think if you go in Google, right, about health IT, there's a wealth of information. And, just comparing the different jurisdictions around the world that have got a big emphasis on health IT would be places like Australia, UK, US, in terms of, many of the ACOs, they call it Accountable Care Organizations, all right, that actually look after population health. So like Steve mentioned, right, we've been to many of these places, right, to compare the IT, right, and then when we look at the comparison, okay, one of the key things is this, when we formed IHIS, right, in 2008, one of the systems we admired, all right, in terms of having a similar kind of structure, all right, and the similar structure was to achieve this economies of scale, at the same time, right, providing for that central patient view across different entities. So we looked at Hong Kong, Alright, Hong Kong has got the Hong Kong Housing Authority, alright, which also owns the IT organization under it. Alright, and Hong Kong, similarly like Singapore, has got various clusters, RHSs. But Hong Kong decided to actually build their system, so they built everything. Okay, the entire EMR, everything was built. And you know, in building, it takes many years, right? And also it would require the clinicians' time, right? Clinicians, I mean doctors, nurses, pharmacists, and all those who are involved in the use of the system. Right? So as a result, I think they were very advanced, right, in 2008. But because when you build systems like that, right, and you need to have, you know, the concurrence of everybody else, right, in terms of defining your functional requirements and all that, right, I think going ahead, right, and keeping that pace is quite a challenge, especially because the healthcare system itself is undergoing transformation, right? In terms of going from very acute focused care to now population health, which is what every country, you know, in the world is looking at as well. So because of that, right, I think the ability to actually develop their IT systems to flow, you know, with what is needed, okay, is somewhat impacted. Okay, then we look at another jurisdiction, UK, right? In the case of UK, well, you know of the NHS, right, the National Health System, that invested £12 billion, right, in the system, and it was supposed to be centralized, and they did build a centralized spine, which is just the infrastructure for network and security. But other than that, okay, they flipped, you know, from a centralized philosophy to a totally decentralized one now, with a change of government as well. All right, when Labour was in, right, we were centralized, and now, you know, they've gone. David Cameron said, okay, you know, everybody needs to have your own path, you chart your own way, and so they have gone to select their own systems, and now they're, you know, kind of 1,000 flowers bloom. And then we looked at the US, right, Kaiser Permanente, Geisinger Health Systems, Centara, and so on. All right, these are examples of very good systems, all right, that also, like us, right, came from disparate systems, right, even though they were under the same group, but there was this protracted IT transformation that happened that actually unified, you know, the entire, you know, technology, right, that served, you know, what the clinicians needed to do and what the organizations needed to do. In the first place, it was health managed organization, which is, you know, to provide for the best care, all right, at the most cost-effective rates. And right now, you know, they're actually aimed at providing the best value, all right, best value care for every patient. So they're kind of a success story, but of course they spend a lot of money, all right, on IT. So I think when we look at Singapore, right, we learn from everybody else, right? So we decided to have a build and a versus buy philosophy, where, you know, we buy, right, wherever we can, and we build when we can't buy. So that has been our philosophy, and that has actually enabled us to actually ride on, you know, many of these good buys, right, or what we call custom off-the-shelf systems. That means EMR, which are actually pre-built and they're sold by commercial vendors. And the good thing about these things is that they actually ride with the wave. So if the wave is going towards population health, the EMRs are actually geared towards that. And you don't have to build specifically for those. So we build where we can't buy. For example, you know, our MediShield systems, very complicated, right? This whole system of co-pay for your healthcare, as opposed to universal healthcare coverage, right? Where, you know, universal healthcare coverage means you don't pay a thing. Like in NHS, right? You can get your glasses for free and all that. So this I think, less ownership on the part of the patient. Whereas in our Singapore philosophy, is, you know, this is actually based on a means-tested co-payment. So you pay according to your means, right? And then if you can afford it, you pay more. If you can't, you pay less, right? So this has actually worked well for us. But as a result of that, the IT system takes the brunt of the complexity. So that while the users, you know, that means the registration clerks and the billing clerks and all that, right? For them, it's very easy. They just look at the system, administer all the complicated schemes. But where is the complication held? In the IT system. So for that, we had to build. It was not possible to find a similar system of very complicated medicine, MediLife and all that around the world. So we actually built some of these, right? But we used a base system which is custom off the shelf called SAP. So we use the SAP modules, all right, to tweak about our very large part of our MediSafe, MediShield and all that were built. So that's actually has worked well for us. Okay, and I think the other factor that worked well for us is the fact that every one of our systems, which is actually deployed, all right, is deployed for the users. So our governance basically dictates that every system is sponsored and owned, all right, by the users, facilitated by IT. Okay, so that partnership has enabled us to build systems which are adopted from day one because it is built specifically for these people who have defined all the requirements and who've been in the testing, the user acceptance test and all that, and they've been a partner on the IT journey with us. So I think that has been, kind of the lessons that we learned and what has worked well for us in terms of us being able to actually manage IT at a cost-effective rate that supplies, the needs, supplies to the needs of the clinicians.
All right, let me change direction because I think we respond to the audience. A few people wanted to know about international comparisons, and we sort of did that in a focused way. Now, there's some questions here about who owns EMR data in Singapore and concerns with the management of data. And rather than just throw that over to Yok Sin, all of you, to some extent, are involved in that. Jason, you sort of helped us understand this complex ecosystem when people get out of the acute care systems. Although to start things off, EMRs were essentially built for the acute care hospitals, and then it's spreading. Bastari, you guys see this from the perspective of one health system. You see it from the perspective of the one who's sort of creating the whole enabling EMR system. Jason, why don't you give us your take on concerns with EMR data? Let's not get into the security issues yet. Everybody sort of jumps to that. Let's just sort of treat that as a separate issue. We'll come to that later. A bunch of you asked for that. Just about who owns the EMR data, who can access it, and what are some of the challenges that, as you see through your experience, what are some of the big challenges on the horizon now with EMR data from your perspective?
Think of it in multiple layers. There's the layer which is at the client end, people who use the service, and to some extent that is the difficult part. Let me just slide into security as well. But you just have to make sure that the right people have the access to things they are allowed to have and so on. So security classically is confidentiality, integrity, and availability. And so those, the CIA has to be taken care of for the users. So that part of it has some level of complexity that needs to be managed. Basically, the general rule within healthcare is that you should only get to see and use data that you are supposed to see and use. So in a way that's simple. To implement is a bit difficult, but the concept is simple. Right? So I can only see the data of my patients who are seeing me. I can't see the data of somebody else's patients and so on. Now, if you go further back, at the systems level, who owns the data? The general rule in Singapore legally is that the owner of the data is the person who owns the asset on which the data is captured. So if it's on my server, I own the data. Now, if this data is about you, you have rights to that data. You can have control over who I share the data with, what I use it for, and so on. But the data is nonetheless not yours. It's about you, but it's not yours in that sense. There is a Personal Data Protection Act within, excuse me a moment. Okay, too much technology. Okay, so there's a Personal Data Protection Act that deals with how to collect, store, use, and dispose and share data. And there are quite a lot of rules around that. That protects the rights of the individual about whom the data is of. So where was I? So at that level, so in terms of strict concept of ownership, the asset owner owns it. In terms of rights, the data, the person about whom the data is of has got confidentiality rights over it. And so that's how it plays out in Singapore. Right? So you can't have someone coming in and say, that's my data, I want you to do this with it. Because if it's about me, even if I tell you, I want you to change it, right? You can annotate it, but you don't really have to change it because it is still, you still have ownership rights over it. One level down, which is kind of what you alluded to, and is actually the most insidious part about it, is the data level, the definition of the data. Because you have some hospitals in Singapore where race is Chinese, Indian, Malay, others. Some of the others goes Chinese, Indian, Malay, Eurasian, others. And they're all different formats, for example. Just a very simple example. And in some cases, the data is not mappable. Right? So at that level of data definition, what does this data element actually mean? I've got values in there, what do the values actually mean? It can get really complicated. And that's actually, to me, the biggest problem. Because it's well and very good for a colleague of mine said recently, just connect the two systems together. Right? Yeah, but you see, if I have data that says, for example, patient comes in the morning and in the afternoon, but you have to say morning or afternoon, but our time bounds for morning and afternoon are different, then if I just transfer it across to me, it means what you're supposed to have meant in your institution, but now I'm reading it based on my definitions. So laboratory results have got normal ranges, the ranges vary. So I can see a patient with certain levels 8.1, it might be normal. Based on this lab, it may be abnormal based on that lab. So there are a lot of contextual difficulties we have with the data definitions. And I think that's the biggest challenge we haven't really tackled well enough. Because we've been trying to bring the data together and then we worry about the definitions a little bit better.
All right, Bastari, when we introduced you, it said Chief Transformation Officer. And when you spoke about some of what you did, one of the initiatives, it's not the only initiative you do, but one of the initiatives that you do that you spoke about was population health, right? So just in the things that you do in the hospital, and sort of what you encounter every day, where is EMR coming into the picture, if at all?
Personally, for me, not much, because my work is predominantly out in the community. The only in-house work that I'm currently doing is only looking at the model of care. Right? So I'm an administrator, I don't deal with patients, so EMR is not. So the only time that I come into contact with so-called patient data is when I go out and do the screening.
All right, so this is important because while Singapore has been very active on the international scene and moving very rapidly in the EMR, that doesn't mean it's everywhere. And when you go do population health things, you don't sort of run across it, at least at the moment. We've got it in our large public central hospitals, what we call the acute care ones. And it's just in the early stages of the process of moving beyond that. So even though we're very advanced in EMR, it still sort of has its limitations of scope and diffusion. Is that a fair statement?
Well, the extension of the EMR to the home, all right, differs from cluster to cluster. For example, in telehealth, right, we have in NUHS, the National University Health Group, right, there is a program, right, which is for heart patients, okay? So what happens is that if you're a heart patient and you had a heart attack, right, when you get discharged, you get a kit, right? In the kit, right, you have the SpO2, the meter that measures your blood oxygen. There's a blood pressure meter, right, and also something to help you with the titration of your drugs, for the blood thinner. Okay, because you have to take all these medications, right? But at the same time, how much to take and whether you're okay or not, right? The doctor will dispense, right, this kit for you, so that for the next 2 months, right, you measure every day. You in the morning, I think it's 3 times a day, you take the readings, and off the reading goes straight away, right? There is a Bluetooth device, all right, with a 3G card in it. So what it does is that it actually automatically transmits into the EMR, right? So that's one example where the telehealth records go into it. So based on that, if there is an alert, meaning that readings are no good, for a few days, then the doctor, not the doctor, actually there's a nurse carer, right? So the nurse carer will be alerted, and then she'll go and call the patient in, for a consultation and so on.
Yeah.
Okay, so that's an example. Then there's another example, Eugene Shum's project in DHA, okay, where they have got also same thing, diabetic patients at home monitored, and then the results actually go back into an intermediary EMR and then back into the main EMR. So with that, we hope to have population data basically, right, over time. So those are examples, and then I guess for the aging in place, they would also come into the EMR, after the collection.
Right. Since you know a lot about EMR because you're part of a large group that's been doing this in a big way over an extended period of time, even though it might not be happening at this moment, can you look ahead a year or 2 or 5 and see where there'll be some intersection over time between what EMR is and what it helps with and what Bastari was talking about earlier about population health? Where do you see an intersection emerging?
So many of the EMR systems, as we say, right, because they are bot systems, and many of the jurisdictions in the world are going into population health. Actually, population health is about, as Jason had mentioned very well, right? You stratify your populations according to risk factors, right, so that you can manage each of the population better, right, applying the resources, not in a mass way, but in a very targeted manner. But I think population health is actually just a precursor to personal health, right? Personalized health. I think that's where everybody wants to go to, right? I think we do not want to be mass treated, right? But you want to be treated according to your own peculiar conditions. So the way the EMRs are going is that they are now geared, right? The next generation EMRs, right? They are coming with all the upgrades and all that of the present EMRs, right? Will have the population health factor. That means they have, with all the records in there, right? And you need to have the risk stratification module, right? And then you also need to have the case management modules, right? That manages cases. You also need to have, of course, we have the longitudinal method, right, which is already present in the national EHR. So the EMRs will evolve to population health enabled, right, to become population health enabled. And so there will be, as you say, where is the intersection? So we will have data warehouses, like today we call them data warehouses, but very quickly they're going to be like big data, and basically the analytics, right, is going to play a very big role in there. The analytics will provide for predictions as to what to do about this patient, right, by gathering information, right, that is already captured in his health record, right, and complemented by his, hopefully, his telemonitoring, right, records as well as his fitness records. So with all these, right, and if you have a module working behind, which does all the predictive analysis, so that's what the next generation of the EMR will do, right? It will be population health enabled, moving towards personalized health with a case and a case manager, right? Telling the case, the case manager as in the person, all right, what to do about the patient. Beyond that, right, we have patient portals that will actually stream and take the same patient record that is present in the EMRs, right, for the consumption of the patient. So the patient can actually view his own records and see what he needs to do in terms of what Bastari mentioned about the social aspect of it, his dietary advisory, nutrition advisory, right, what things to avoid and all that. So that's actually where healthcare is moving towards. So it's moving towards more integration among apparently disparate functions, okay, to provide for a more holistic healthcare for every person.
Jason had a comment here. Oh, you got it.
Just to add to that, I find it useful to think about what I'm talking about, in the sense that we keep saying EMR, but what do we actually mean by the word EMR? And I know a lot of you are IT guys, so you think of EMR as a system, right? With subsystems and so on. And so if I ask you to come up with a visualization, you probably come up with some diagram which shows servers and stuff. That's one way of looking at it, which is the direct way, especially with implementation. But another way of looking at it in terms of data stores, what data is out there. In our mind, it's going to be lots of symbols of data and so on. But for the healthcare sector, right, an EMR is actually not an IT system per se, or just that. It's not a data store. It is actually a collection of processes of care that are given to the patient because this system enables it. So if you think of it in that way, the patient comes to A&E, gets tagged, and all these things happen, blood's ordered and stuff. If you define the emergency EMR system as supporting these processes, then the question becomes, when does it become a population-based system, right? To be able to follow up patients at home, get data from them in real time and track them and so on, which is what NUH has already done, right? If you define the EMR as including that service, then actually NUH already has a population health-based system, just that they have to figure out how to extend it to all the other departments. So my main point here is more that, so when we talk about EMR, the future directions, we should be not looking at adding sectors or clients, but rather adding care processes and define the EMR by what care processes it can do, rather than the more technical framings.
All right, I had some quick things here. 9 people had asked, what is the cost to receive a health screening? Can someone explain what is a health screening? And then can somebody explain what is the cost of a health screening?
Okay, health screening, what is it all about in the Singapore context? Okay, so under the national guideline, right, there are certain screenings that are being done as what we classified as category 1, means that it is suitable for population level, right, based on the stratification of at risk. So right now, anybody who is 40 years and above, the recommendation is you should go for a basic health screening. And what does the health screening cover? Well, 3 things, right? When we go in to do health screening, we take 3 clinical measurements. Blood pressure, as I told you earlier, and we wanted to draw their blood to measure blood sugar and the cholesterol. At the same time, the other measurement that we take is their height, their weight, and waist circumference. Yeah? So we also then take into account, because as you know, BMI is another risk factor. Okay? Now typically when we go out into do the health screening, we go beyond that because we also begin to collect data, which includes the data on basically the demographic data. Because I'm not sure that you realize that when the patient actually interact with us at the hospital, we only have very limited data when they come in. So we go out into the community, we take the opportunity of expanding that, right? For example, we also need to want to know where they're staying, who they're staying with, what's the education level, right? The language they speak, right? What job they hold. So more of such information, because at the end of the day we realize that health is not just about the state of health, because sometimes when you go out to the community, what you see is their health is actually a manifestation of the social issue. So that's the other complication that we see when we go out. Yeah.
That's the correct answer. But I want to throw something else at you, because I work in healthcare IT, I worked in private sector business, and I tend to look for commonalities between them. So for the IT guys out there, a health screening is the same as a systems check. There's no bad sectors, CPUs functioning okay, not overheating and so on. For the biz school people out there, it's due diligence, enough cash flow, enough reserves and so on. The directors good character and that kind of stuff, right? So in both of those things, the general principle, in both of those, as well as health screening, what you're looking for are things that could signify something is wrong. So, in a sense, for you, the details of the health screen itself, leave it to the clinicians, but basically what you do is you're just looking for things that are red flags, that they need to be taken care of, and the choice of red flags depends on the population, the people that you have, and so on.
Okay. Just so we get responsive to some of the most frequently asked questions, as any story with population health, because you're sort of out there, it would seem that the everyday corner clinic, the general practitioner, plays an important role, because for most of us, okay, I get a stuffy nose, I feel this, I feel that. The first line of interaction is always the neighborhood clinic, right? So a bunch of people ticked on the question, what are some strategies to get GPs on board? Now the question here says to get GPs on board with using newer technologies. But maybe that's not even the heart of the question. What is the question to get GP, what are the strategies to get GPs on board? And what is it that we need to get them on board with as we sort of move forward in this more expansive concept of healthcare? Who'd like to take that?
Let me. All right. From my perspective, what I would like to get the GP on board with is more, because I think, Steve is right in the sense that if you look at primary care, right, GP is at the forefront because they accounted for, in terms of numbers, 80% of the resources on the ground to tackle primary care. Whereas for the government, right, we deliver primary care to polyclinic, from a resources standpoint, it's only 20%. So the Pareto analysis, right? So GP 80%. So we need to get the GPs on board to make sure that primary care is very well taken care of. Right? Now that should also include health screening. There is a scheme actually in the government said you can actually go to a GP and get health screening done. Can't quite remember what's the cost. Do you remember what the cost? Anyway, you can actually go to the GP and get health screening done.
Actually, from my limited experience, they're as inexpensive from a handful of dollars. I don't know whether it's at 5 or 10 or 20, but something at the very low end to tens and tens of dollars, to hundreds of dollars. And then, of course, the private hospitals have your $2,000 health screen package. So you pick a price point and you can find it.
Yes, that is true, right? So that bit, for health screening, actually that's been done by us. We provide it free. Okay. The only thing is that so-called the residents actually pay is only $2, and that is more as a commitment fee, right? And we do it in the community. Right?
So money is not the issue.
Money is not the issue, right? But getting them to come down, duly fasted for the last 8 hours, come down to go do it, is one of our challenge, right? Because a lot of people, unfortunately, go into the illusion that I am well, I'm fine, right? I'm not at risk. That's one. The other one is, I'm well, I'm fine, let's sleeping dog lie. Right? I live in a bubble, I'm fine with that. I do not want to know what's happened because once I know what happens, I need to change.
As long as I don't know, I'm healthy.
That's right. Because the minute I know I have to do something about it, and I do not want to do something about it because it means a change in my lifestyle. Right? So these are some of the things that we see on the ground.
Yeah. Yoksin?
Yeah, I'd like to address the issue about why does it take so long for GPs to adopt EMR, right, or to adopt an IT system? Okay, the reason is money. Okay, because you see, for healthcare systems, right, for public healthcare, you have to actually put in all the records and all that because you have to work with it. So it's a given, and everybody's a salaried employee of the system. Now, when we actually roll it out to community hospital, right, there is a subvention or funding of every patient that they see. And the only way to do that, right, is that we incorporated that subvention in we call Community Health Computer System, CHCS, right? So we provided that a system that allows them to also collect, their subvention from the government. So that was widely adopted. Then came the nursing homes. The nursing homes, same thing, right? They had to submit, very laboriously, right, the paper claim forms, right, for every patient that they had to write, religiously on the form, rememberingly to capture all this information when the patient gets admitted, it is in the home, right? So for all that, right, it was very cumbersome, right? So at first it was paper submission, then we had something called a file transfer submission. They did it on the computer, but it's actually one as a document. They would submit that. Then we provided them this nursing help, right, which is a nursing home electronic system that gives them the ability to automatically, right, when the patient comes in, when the person goes in the nursing home, right, all the information is captured, and out of that, right, that automatically gets submitted, for the claim, right, from government. So actually it's about money. For GP, right, we haven't had that case as yet, right, but we're starting to have that with something called CHAS. CHAS is the Community Health Assistance Scheme there. So if you're a pioneer generation person or if you are on the scheme, right, you have a card, a blue card, all that, right, the orange card, you are entitled to the discount, right? And what happens is that as a patient, I can go to a private GP, I pay the same fee that I would pay as if I saw a polyclinic or a government GP, right? Then the private GP collects the balance from the government. So that is beginning to kick in, and for all these CHAS accredited GPs, right, we've actually started to extend the system to them, and they have adopted that, right? So I think it's over time, right, that every GP becomes a CHAS GP, right, and that's when the system will be readily adopted. Okay, so there must be a motivation for adoption.
All right, we're gonna head towards wrap up. Jason's gonna make a comment on this question about getting GPs on board, and then we're gonna do one final round. So hold your breath, a little bit of energy, a little bit of attention, because we're gonna sort of head towards ending. And you make your comment, and then I'll take us to the very last question.
Just wanted to compliment what you've been saying, because one reason why GPs don't take up IT is because of cost. There are GPs out there who do a lot of IT, but those you look at them, you know who they are because they look really like geeks. So they are early adopters as well. But I think and I raise this point because it would have relevance to the case study you're doing. Because the other reasons why doctors don't take it up is because it's actually just not convenient. They're not used. Why do you think doctors' handwriting is so bad? Look, one reason given is that in medical school you copy a lot of notes, right? But the other reason is they're not looking at the paper. They're looking at the patient, talking to the patient, and writing at the same time, right? And that's what actually happens. So they're able to look at the patient in the eye and talk, and that's part of the doctor-patient relationship that you try to foster and so on. You put a computer in front of them, they can't type, and most doctors, the older doctors anyway, they can't touch type. So they have to look at the screen, they have to look at the keyboard. So they lose eye contact with the patient and it becomes very slow. So there have been studies done which shows that when you put an EMR into a department, in a hospital department, they take 3 times as long to look after any one patient because of they can't overlap their data capture and their patient contact time. Okay. So I raise this because when you recommend your solutions for the case study and so on, don't forget there are a lot of people factors, human factors. It's very well and good to say, oh, okay, we have this IT system, the doctors will use it. Some of the doctors will love it and will help you to build it. The other end, some of them will fight it to the last drop of blood and refuse to use it. And you have to realize you have to deal with these people issues when it comes to these type of systems.
All right.
I have to respond to that.
Oh, okay.
I think what Jason said is true, right? But over the years, this has changed because, nowadays, right, I get requests from the doctors saying that, why isn't your IT moving fast enough?
Those are the geeks.
Yeah. The geeks have grown.
I was a geek, okay?
Yeah, the geeks have. And then the older doctors who wouldn't do it, right, they sort of have retired or they have actually asked the MOs, and the houseman to do it.
So that's changing, right?
That's changing.
So, final question. So here's what was written. What was written is, what are some of the strategies to get the aging population to utilize tech to aid in the treatment and monitoring of their health? All right, so let's say we're not talking about we're in the hospital, right? Because if we're in the hospital, that all gets taken care of. The aging population, and they're not in the hospital, right? Not some acute incidents. What are some of the strategies to get the aging population to aid in the treatment and monitoring of their health? Now, again, on this one, there's no one simple answer because they're the geeks and the I don't want to get involved. There's a wide spectrum, right? This is sort of the population of the population, if you will. So any comments on that?
Okay, I think Yosin mentioned about the pilot, right? We also did a pilot with the population, right? We trialed the technology that Jason alluded to in terms of trying to census to monitor patient who fell. Now, when you deal with the older folks, you just got to take into account the fact that they are really not technology savvy. Okay, and you got to make it as simple as possible, right? Please pass, and it's not something that they got to remember to do every morning. It will not work. It must be something that is part and parcel of their daily life and you bring it into their lives. Okay? So we also did another pilot where, so one was we installed a device which is able to detect fall, and that device subsequently can even basically validate at the first level because it was then valid, there's an interaction as well. From a call center, we were able to go do that. It was a small trial that we did. Another one we did was with monitoring, similar to what you said in terms of National University of Hospital. Same thing, we put in sensor to, basically we put in blood pressure and weight scale, right? And that data then subsequently sent to a central monitoring, and the nurses were supposed to monitor. So it's a small scale. One of the issues that we faced was, how do we know that the data that's been sent was actually the patient's data? We have instances when a certain day suddenly, especially with Chinese New Year, right, we had numerous data streams that came in, and later we found out was the whole village came to visit and said, oh, this is fun. Right, start jumping on the weight scale, and we got the data stream that came in, and so all our readings went bonkers, right? So that's one. Yeah. So again, as I said, it is a question of how you make sure that is done. So adoption, the strategy, and when you also deal with these old folks is where finances are tight. They do ask the questions that, okay, you plug this device, right? It consumes electricity. Who is paying for it?
Right, as minimal as that is as an incremental cost on their electric bill, you're saying it's still a state of mind thing, right?
I'm a public health physician. Public health is a medical discipline that's similar to cardiology and all the others, just that it's not so well known. And I tell people that public health is the easiest of all the disciplines because no matter what public health problem you have, you only do 4 things. Okay, and this is useful for you. Okay, One, okay, is you educate people on the right thing to do, on why the bad thing is the wrong thing to do. Two, is you enable them to do the right things, or disable them from doing the bad things, right? So if they are glue sniffing, take the glue away, right? If they are, and so on, okay? Three, right, is that you scare them somehow, right? Which is why cigarette packs these days have got horrendous pictures outside, and people show things that. And if you have something that there's no consequence to the person but to somebody else, like when you pass a law and you punish them by jail or something, so you scare them with something artificial, but you still scare them somehow. Okay, that's motivation. And four, right, is you think about it and ask yourself, why are they doing this? Right? If the kids are glue sniffing because they're bored, then you give them a skate park, you give them free movies, you give them space to do break dancing, they will be distracted, they'll stop doing it. Okay, so you enable them, you educate, motivate, and redirect them. Okay. Now, if you take those four things and you cross it with the population you're looking at, right? The people out there, they're the old who can't see the screen, right? They are the young old, very active, and they go out every day with their qigong and the kind of stuff. You segment types of people and you draw a grid, four directions of what you can do, different types of people, and you say within each one of them, what do I do to get this thing to happen? And if you get it right, those segments will move. And those segments are the ones that will start showing you results. Now, I say public health is all disciplines in a sense, because the solutions are easy to figure out. The challenge is to do a lot of those things. You must get your politicians involved, your grassroots involved, you must get the funding, getting the ministry to agree. That's the hard part. Okay, so, but you are here to just propose solutions. You don't actually have to get the minister to agree. So this gives you a way of looking at how to come up with to create solutions for whatever case that you have.
All right, we're essentially done. We're wrapping up. I did see one person raise their hand, and one individual had some personalized question they wanted to ask. Well, now we have two. Okay. Here, what is that question?
I was wondering about, I have a friend who's a nurse, and one of the number one problems she runs into with patient care is multicultural, multi-faith, and that they don't want to take the treatment because it goes against their own beliefs. How do IT solutions take into account that type of personal, unique situation?
This is quite prevalent in the US, for example, right? On Saturdays you cannot move. So, yeah, I mean, New York, because I went to visit that, was it Mount Sinai?
Oh, well, that would be if they keep to the Sabbath laws or something. I mean, that's not prevalent in the United States, but that would be a subpopulation in that one unit. Yeah.
Actually, the EMR should have an indicator about what to do for the patient, right? And also things like ECP, his care plan. I mean, in the sense that what does he want? Does he want to be resuscitated or not in that event? So these information are also in the system. Okay, and nurses will then know what to do. But I think beyond that, we have got, for example, languages, right? If they can't understand language, because many of our nurses actually are also imported. We have a shortage of manpower. So in two of the hospitals, there's something called an iPad communicator that it's got a picture of the toilet, food and all that. So the patient presses, and then out comes the language. So if it's like one of the dialect Hainanese, right, it comes out in that language, and then he says yes or no, and then it goes back into the system. Into the iPad again. Right, and then it will translate into, but it's quite loose, because it's quite limited, right? So it's either yes or no kind of response, right? You want to go to the toilet now, or yes or no, right? So in that language, so the nurse then will know what grandma means.
And you probably are well aware of this, but I'll say it for the benefit of the rest of the audience. It's not how do IT systems take aware of this. IT systems are the expressions of designers and policymakers. And it's really how do we make choices so that we, like you say, I want something that will facilitate social interaction or translational interaction, you know, and how do we use technology to enable that? Now, it was actually the fellow next to you, or was it you? Who it raised? I'm just testing you guys. All right, what is your question?
This is specific to Astari. You just said you're kind of motivated to try to get everybody from the population to come in and get those screenings and treatment.
Well, is it come in or go out? It's to get the people to get the treatment. Is it literally to get them into the hospital, or to go out where you do it in the community and just show up?
You said, yeah, because you said you were set up in the community and for that 8 hours, and you're having troubles getting people to actually come in. And I was wondering if people, so say there was a solution that was out there and it motivated a lot of the population to come in, would it actually have the bandwidth to kind of, treat them or give them the screenings?
Now, the 8 hours was a different thing. It's that we need them to fast for 8 hours before they come in.
But
yes.
Yeah, but then coming in was the big problem.
Right.
But say, so we get them to do that, and then they come in, but we've motivated a lot of people to come in. Is there actually that bandwidth there to actually facilitate that?
What happens if they do all show up?
So we proposed this, and now everyone's in here. Great. Can we actually handle it? If not, what's the scale up? How do we kind of scale to meet that demand?
Okay, good question. I think it's, yes, there's another challenge that we face on the ground. Because when we move our team out, we basically send a mobile team, right? So we have to go in, we have to register them, we have to ask questionnaires, right, in order to collect the data, right? Then after that, take measurement, and again record the data, and draw blood, and we want to make sure that we have nurses. So it is a small mobilization. It's not something that is to trifle with. Yes, if we are able to get, now recruitment is an issue. You would have thought that if we make the announcement and all that people will just come in droves. But the reality is that the largest crowd that we have ever had in one particular screening or on a weekend was, I think, about 330 people.
Which is small, right?
That is the largest crowd that we've ever had. And what we did was we sent a team of about, I think, 30 people to manage that. And that is from our hospital, not to mention that the grassroots organization who we work with, because we're doing it in the community, so there will be the grassroots staff who are organizing it for their community. They themselves will mobilize their resources, right? And we typically spend about 3 hours, thereabout, to complete the whole thing.
3 hours per person?
No, the whole cycle.
The thing. I go to weddings. There are more people than that, and all these people go to weddings, and they don't know what to do once they get there. They're sort of bored. You could sort of combine it with the health care. And you're going to feed them anyway, so they can fast. But, I'm sort of being a little bit of a joker here, but what you're saying indirectly is we need to find creative ways to combine this with the social fabric. Because no matter what you do, just sort of like drop everything else you're doing and show up for the health screening, we're not getting the volumes we need. Now, show up at Hungry Ghost Festival, people show up, So how do we start to sort of combine these things in creative ways? Yeah, all right, well, we'll leave that. I think we have sort of gotten to the end. You've probably gotten a little bit more exposure to health issues than you ever knew that there was to know. For some of you who are in your school programs and they talk to you about market segmentation, right? Did you ever think the concept of segmentation would be so important to understanding health issues? No? Interesting way to sort of combine these things. So there's more things that maybe you can go out and do with the background that you're doing other than to sort of just meet routine sales quotas and other things business-oriented students go do.
One point.
Yeah.
What you say that public health is the easiest
And the hardest.
right? Take it from me, implementing it is the hardest. Motivation is a big issue. Scaring them is only one of the many tactics. If scaring them works, then the picture of the cigarette boxes should result in a reduction in smoking.
Yeah.
Okay, so you guys are doing it.
All right. Thank you, everybody. This has been great. I just want to say, all of these people sort of have a lot of responsibility just in the few hours being here. Now they have more emails than they can answer today. And, it's sort of a little bit of a personal favor and a small sacrifice. So on behalf of Apex, I would like to thank these people for sort of reaching out to this international community. Thank you.
Appreciation to our panelists who present the event. Team leader, please.
Okay. I bet we're getting 3. Yes. How appropriate. All right, so here we are. Jason, thank you. Okay, these are not named, are they?
No.
Okay, thank you. And Bastari, thank you again. This is great stuff. Thank you. Thank you.
Thank you.
All right, this has been great. Thank you.
Good morning. My name is Carly. I'm glad that you finally pronounced my name correctly. I always often joke with my students. Car as in car on the expressway. So that's an easy way of remembering my name. My name is Kawe. I'm with the School of Information Systems. Today I'm going to share with you some of the work that I've done, and together with a group of undergraduate students. They are Team Code Blue. The names are Narcis, Clarice, Chun Young, sorry for the mistakes, SYNG, Nigel, Faris, and Safi. They are all busy with their internship and pursuing their exciting career, so here am I giving you this talk. The previous speakers has already given you a very good overview of Singapore healthcare, from primary care to community care to home care. So today I thought perhaps I could give you one specific example of how we can make use of the data in healthcare or hospital to make better decisions. So I'm going to talk to you about proactive processes. I'm going to share with you what do I mean by proactive processes in the context of using it in emergency rooms or emergency department, or in Singapore it's often known as the accident or acute emergency department. Okay. So the problems that we are facing today are probably not new to you. It is growing cost, growing needs, and according to this survey, many of the emergency department is already at capacity or over capacity. How about in Singapore here? In Singapore, in our A&E units or the acute and emergency units, we face a large number of non-emergency patients. Give you a little context about what emergency patients are non-emergency patients. The emergency patient actually takes care of have patients coming in 4 different levels of acuity, P1s to P4. Okay. P1s and P2s are generally critically ill and in severe conditions. P3s and P4s are the ones who are non-threatening and have moderate symptoms. So the P3 patients or the non-emergency patients face long wait time. So how are we prepared to move forward if given that resources are limited, given that we need to make other decisions without forever increasing increasing resources. So I'm going to talk a little about proactive processes. Earlier, Yosin talked about in the past there was a lot of paperwork. The nurses are filing paperwork in her previous discussion. So in the past, it was manual processes. It's all paper-based and it's inefficient. But in today's world, in fact, a lot of them, we know that hospitals are already supported by IT systems. Automated system, interactive system, and manual activities are already eliminated. And most of the activities are supported by IT. So what's going to be next? Current and future. The current and future, we do want to look at proactive processes. Processes that know how to react when something happens. If there's a sudden surge in the emergency room or there's a sudden surge of patients coming into the hospital, what can be done? If the emergency department cannot handle that kind of demand anymore, can we know what kind of patient can we then direct to community hospital, or how can we direct some of these patients to the GP, general practitioners? So we are looking at processes, or rather proactive processes that give intelligent decision support based on data, historical data, real-time data, and provide dynamic policies. So let me give you a case study at a local hospital. The problem is that there was 70% of the non-emergency patients. The resources are limited. We cannot keep increasing the number of doctors, number of beds, number of nurses. And the hospital targets to clear these non-emergency patients within a certain time. The reason for this is that the Ministry of Health do have a regulation, or rather a guideline for the emergency patients, the P1s and the P2 patients. So hospitals do have to follow the guidelines. But the non-emergency patients, the hospitals do make their own guidelines. So typically, in the emergency department, it's segregated into two different areas: the critical care area and the ambulatory care area. The critical care area takes care of emergency patients, and the ambulatory care area takes care of the non-emergency patients. So our aim is to then serve these patients in the ambulatory care area within a certain time, what we call length of stay. And length of stay is typically defined as the time when the patient joins the department to the point that he or she is discharged. So going back to the question, if given limited resources, if we don't have the ability to increase resources, what else can we do? Are we then stuck? So the proposed solution is to have some form of dynamic queue management to manage the queue from both the supply and the demand perspective. So we model a single process in an emergency department. This may be familiar with you. Patient goes in, we do a registration, triage is where the nurse has a preliminary assessment of the patient to give them a acuity level. And then the patient will then wait for a consultation with the doctor. And if a patient requires a test, let's say a blood test, an X-ray test, or sugar test, then they will go and take the investigative test and treatment and rejoin the queue to see the doctor again. And this can be repeated multiple times. We call these patients that are coming back to rejoin the queue as re-entrance to the queue. Thereafter, a patient can be discharged or be admitted to the hospital. Okay. For those of you who may be familiar with queuing theory, you know that a queue like this, with a patient coming back multiple times, and then throw out the queuing, a standard queuing model, that you cannot find a specific wait time. So that makes this very challenging. And of course, there's other complexity that goes into this process, like time varying arrivals. There are less patients coming in the midnight to 7 a.m. as compared to the hours between 8 gets all complicated by the various parameters of the process. So I can easily take a few hours to talk about all this, but given the limitation of the time and our lunch, I hope that I'll just give you one specific example. Okay? So we did come up with some form of demand-side strategies like short, really algorithm like shortest consultation time first, shortest remaining time patient. So this part, which we want to prioritize the patients dynamically based on a certain parameter, like whether the estimated consultation time or the time that we targeted to clear this patient. So on the supply side, then we look at how do we staff the doctors using some strategies like using real-time data and historical data to help us to make better decisions. So the specific example, at the patient prioritization strategy, shortest consultation time first, the aim is to clear the patients who has the least estimated consultation time first. So given a patient A and B, if B is waiting in the waiting room while the doctor calls for A, and he spent there sitting and waiting, and finally, after 30 minutes, the patient steps up. And when B enters the room, and because maybe perhaps he's a frequent flyer, as mentioned by Bastari earlier, then he already has his historical information. Or maybe B is a patient who has taken the blood test and re-entered the queue, and he has all the blood test results cleared, and the doctor says, "Oh, I think you are fine. Please go back home, take a rest, and if you have any, monitor for the next 3 days." So how would B feel that I waited for 30 minutes and I go in for 2 minutes? So this is a simple algorithm that says that, okay, if we can better estimate these patients, how much time they need to see a doctor, perhaps we can then let B go in before A. Then how we do that? I will not go through the rest of the strategies, but give you an example of how we can make use of data. So a patient in the queue here, suppose this is a review patient. We know that the EMR records mentioned earlier is all captured. They're captured in the laboratory systems, X-ray system, and these other supporting systems, like the cardiology system right over there to the right of the screen. And can we then estimate the consultation time based on the patient's test results? So that is that we need to come in, we need to do some data analysis to find the factors that help us to determine or predict how much time the patient with certain symptoms is going to take with the doctor. So suppose if the patient has very few or no problem indicated in the test result, but we can estimate based on that it's going to take a shorter time compared to another patient who may have very complex issues shown in their test results. So that is the other part, the medium to long estimated consultation time. So this part here. So short consultation time, long consultation time. We can now build this decision tree based on factors, based on symptoms of the patients to then better make decisions. So in terms of the resource adjustment strategy, we can look at static schedule that does not change, or dynamic schedule that change over time. So we have like 4 different methods. His is like based on historical arrivals, dynamic based on real-time arrivals. So if there's a lot of arrivals, then how do we then change the number of doctors required to see the patient? We can also build in optimization routine to help to staff doctors ahead of time. For example, if I know that for the last 3 hours, I already have more than usual number of arrivals, patient arrivals. And the next, I know that it's going to hit the peak hours for the next 4 hours. Then perhaps I can put in, if I do have a doctor availability, then perhaps I can start putting in an additional doctor even before the peak comes in. So it's a proactive action taken to help. Earlier during the panel discussion, there was also a lot of mention about healthcare is all about personal, the people is also a very people, it's not business but processes. How do you then think, with all this, the solution that we need to think about is that how do we think about the people, the stakeholders within in the process. For example, the patients earlier, the patient prioritization, how do we present the information to the patient such that all patients are happy? Or in this case, the doctors who probably resting in the bedroom is available, how do we then come up with strategies that help him to feel better by putting him back onto the consultation room? So we do have to consider the human factor when thinking of solutions. Giving you an idea of how things fit together, I mean, we have been talking about big data, using of data in hospitals, but how do things fit together? So this is an example of a queue management system with optimization routine. So you have physical systems here. So any of the physical systems, the X-ray, laboratory systems, hospital system in the databases, can put in the past data and analysis on the data, and we can feed in the data to a system and have the real-time data interacting with this system in real time. So we have historical data, we can have the optimization model within a system like this, and some form of simulator. I'm not going to go through what a symbiotic simulator, some form of simulator to evaluate how good the schedule is. Real-time data and a decision maker's parameters. While it may look a little bit abstract to you, perhaps I will give you a quick demo of what my undergraduate students have built, then you can maybe get a better idea of what it is. Okay, so in terms of result, I'm just going to cover 2 points. We have run numerical test experiments. We found that dynamic patient prioritization does perform better than first in, first out. In the various methods are here, the first in, first out method. And we also found that the dynamic resource adjustment using historical and real-time data allows hospitals to react to demand changes. So the next slide will be a short demo. This is a nice system that our undergraduate student has built. So this page is simply about the setup. If you look at this, it's giving us the arrival rates of all hours of the day and different times of the week. Imagine if you have enterprise systems and historical data analyzed and knowing which the arrival rates for each, you can then link it here. There are other settings here that is to do with how fast a doctor can process a patient, just below. Number of patients served by a doctor per hour. So again, that could be computed, you can find out by analyzing the historical data. And how many percent of clear results to help you to make decisions here. So this is the page of how you can link enterprise data to an application like this. Let us look at the website. So I've already run a simulation for 7 days yesterday night. And here here is what I get. This simulation is run over 7 days with a mixed prioritization strategy, starting on a Monday, target length of stay, within minutes, and service rate of doctor can serve 4 patients per hour. So this application is entirely built by our undergraduate students. I'm very proud of them. So we can look at this. Tuesday and Wednesdays. In one view, the daily patient length of stay. And another view, hourly patient length of stay. So we can know that, Tuesday and Wednesdays is higher than why. So maybe perhaps we'll go and look at why. You can look at the setup as well. In fact, looking at this Sunday, the numbers are like 2, 4, 5, 6, 7. And look at Tuesday, it's actually higher around this. So you can relate, you can do diagnostics. It's pretty fast. So you can choose not to see Wednesdays now, or you just want to zoom in into Wednesdays by filtering away the rest of the days. By looking at which hour is affecting Wednesdays and Thursdays. The other parameters that matters to doctors, that matters to operation heads, you can look at the numbers of re-entrants, because the more re-entrants you have, the more difficult it is to predict what kind of resources you require. And target achieved, how many has achieved within 120 minutes, and how many achieved within did not achieve the targets. And door-to-doctor time, and how each of the doctors is, how much each of the doctors will tell us. So we can do a view playback. This is a simulation. Here we try to engage the healthcare practitioners who may not be very familiar with all these strategies or looking at charts. Then perhaps they can have a better visualization of what things can happen in the emergency room. So let me fast forward this a little bit. So you can look at this visually. You can see which are the how many patients are in the system. This is the startup time, so we have a lot less patients. We usually take away the first day of the simulation so that we look at the first day and the last day, so that we don't look at the cool down time and the startup time. So we have the happy patients in green, we have the satisfied patients in yellow, and disappointed patients when they spend longer than 2 hours. Let me fast forward this a little bit. We can fast forward to day 12. Wow, that's not very nice. That's lots of yellows and red. Let me find some greens. Okay. So you can see how many percentages of the patients replay. Still a lot of red. So you can continue, and then there's some greens, and then there are some. So these icons are the re-entrant patients. And they spend time in the laboratory, and then when they come up to join the waiting area, they have their arm bandaged. Okay, so that's kind of the end. You can continue to play the visualization so that people can understand operation, can understand better. Pause. It will take very long to play this. All right. Let me get back here. So thank you to Team Code Blue. The team members are there. One of them is sitting up there. Later you can look for her and tell me. So in conclusion, I just like to take 3 points. Okay. The data in the hospital is gold, right? It's a gold mine. Uncover the potentials of using data in making processes proactive, which means processes that can adapt when things happen. Effective use of data helps hospitals to react to changes and make better decisions in real time. And moving forward, we should be looking at proactive processes that allows us to make better decisions and be reactive to likely scenarios. Okay, with this, I conclude my talk, and I think you are waiting for your lunch.
do it last night because last night was fun. All of you have your little book, the thing that's got the schedule. Where's the little sort of event book? Right? I think most of you have it. Yeah, she's got it. Right. So turn to the last page of that. I'm going to do the one yes. Okay, let me borrow that for a second. I'm going to do one tasteless thing, but it's better to do it now when you sort of have professional attention. Last night was all fun. So the one thing that we're going to do, which is sort of blatant tasteless advertising, is as you go home and you think about things you're going to do later in your life, not the very last page, but the second to the last page, announces that we have really cool PhD programs at SNU. Right? And you never know. This might be something 3 years from now, or 5 years from now, or a year from now, or something for a friend. But just to let you know, like in the Gold, we do really cool things with IT and computer, deep in the worlds of management and social and societal. We have a very, very unique type of computer science, and informatics group here. And then we do things in psychology, economics, the School of Business. So when you think of SMU, don't only think of what we do for Apex and this sort of super cool thing at the undergrad. Just, you never know. You might tell a friend, and 3 years from now, we might get an applicant for a great PhD student. That wouldn't have happened unless you just knew we existed. All right? So that's my tasteless advertising. Thank you.